Hi everyone. Today is another episode of the ASPN Synapse interviews. Previously, we had interviewed the candidates of the Brachial Plexus International School program, and today we continue our series with hosting this interview with the heads of the school centers. We have Dr. Clifton from Mexico. We have Dr. Bhatia from India. Nice to meet you, sir. So thanks for your time.
It's our pleasure.
Thank
My
you.
pleasure.
So for our first question to Dr. Clifton. So how did this school idea get evolved?
Okay, before the International Brachial Plexus School, I started in 2010, uh, local uh, school in Brachial Plexus in Mexico. And how the idea started, it's very easy. To perform brachial plexus surgery is hard and you need a special training. So I think that if you're going to do or perform a brachial plexus surgery, you should have training.
Okay.
In the old days, that's what happened to me around 35 years ago. If you wanted to learn to do brachial plexus surgery, well, you write to a big professor like Dr. Gilbert, this is Overline, uh, and you go with them if they accept you, and you are part of a team in the time frame that you can go, or they accept you 3 months, 6 months, 1 year, etc. But there were no university program, and you catch the information as you can, and then you go home and then try to start doing surgery.
You mean like there was no structured program for the brachial plexus teaching?
That is correct.
Okay.
So I got the idea of having a university program, with a university diploma. And that means that you need to have some topics. I have around 40 topics that you should master, from anatomy, uh, like mechanisms of injury, physiopathology, physical exploration, basis of surgery, etc. And also that you need to go into cadaver dissection. That's part of the
After the
program.
program, okay.
Yes, and see a lot of patients and start doing surgery. In our program, the fellows do surgery, start doing surgery, and all should start doing brachial plexus exploration.
Okay, that's great. So we move to Dr. Bhatia. So I understand that each center for sure got other trainees like residents or other fellows, which doesn't belong to the brachial plexus school program. So how usually you try to make sure there is no case dilution among all the trainees in one center?
Well, strangely enough, I work alone.
Oh, I
So
see.
uh, for me, it was a godsend that I got to explain my philosophy and strategies to a wider audience. But my thinking was a bit like Jorge. I've known him for a number of years, and the uh, the thing is that I did not want people who are younger to go through the same learning curve and getting confidence with various techniques, spending as many years as I did getting that confidence. To put it in a nutshell, I want uh, every new brachial plexus surgeon to operate his first operation like my 1500th operation. So
Yeah, that's great of you.
that way they see how we evaluate, how we arrive at a clinical diagnosis, and uh, then know what are the possibilities of exploration, document what is the cause of the deficit, and then apply techniques that are current today, not something that was published 40 years ago.
Yeah, exactly. Up to date
So,
programs. Yeah.
because after all, a brachial plexus injury is not dedicated only to restoration of biceps, for example, or rotator cuff, for example. We want to get that limb independent.
Yes.
It is disconnected from the brain, and we want to make it independent. So, what combination of techniques works best in the hands of the experts? They should be able to apply those same techniques with the same degree of fluency as each of us does, like Alex Mouzet or I or Jorge Clifton or Tarek El Gamal. All they should be able to replicate that even in the first 5 cases, and not wait another 20 years to reach that
That level.
fluency.
Okay. And
So
this
that's
program is a 1 year or 2 year program?
we started it out as a 1 year program, because spreading
Mm,
4 visits of a week,
mm,
they have to get absence from wherever they are working, leave of
mm.
absence. They have to program travel so that the dates are given well in advance, so they know they can book their flights. The local accommodation is taken care of by each of us, so
Mm.
that they do not have to travel too much to reach the center.
Okay.
The structure of the exposure to consultation, operations, discussions, that is prepared well in advance by each of us, and we try to organize cases that would uh, give them a broad perspective of the field they are entering. It is impossible to show them everything, but
Yeah, for sure.
a significant exposure to total and partial palsies was looked at at each center.
Okay, that's great. So we move back to Dr. Clifton. So how does the four centers coordinate to ensure smooth transfer or movement from for the fellow from one center to another?
Okay, so the course in the Brachial Plexus International School, to me, is like uh, kind of a master. As I was mentioned, the idea came from the basic Brachial Plexus School. So the basic Brachial Plexus School, it's also 1 year, but it's 1 week every 2 months. So it's 6 weeks. That's the basic. And now
Okay.
that's here in Mexico. And the master or the Brachial Plexus International School is also 1 year, but
Mm,
4 visits. It's around 1 visit every 2 months, 3 months.
mm,
So we have the philosophy, as Anil mentioned, of not going to the basics. So this is like another level of knowledge that we
mm,
have, and every center manage uh, their own staff, their own. Anil works alone, but he also have several surgeons that come and help him to
mm,
organize and do different kind of surgeries.
mm,
So, like the fellows will go 1 week to the country or the center, then go back to the original place and stay there and work
mm.
around 2 3 months, and then go to another country, to another center. So we want them to have an international view. I have my philosophy of brachial plexus, that there's a lot of things that we share with Anil, but not 100%. There are
Yeah, for
things
sure.
that are different.
Yeah, for sure.
Uh,
Especially for
uh,
brachial plexus, each center is like got a unique strategy, I guess. I mean, there
yes,
is a common area everyone meets at, but the different center got different strategies.
yes. So we have centers that have more birth brachial plexus injury, and centers that have more adult brachial plexus injury.
Mm.
So that's
Yeah,
me.
this one of the things the fellows actually highlighted, like the flow is different from one center to another.
That's the idea. So
Mm,
they have a broad view of different injuries and different way of treating them.
Yeah, that's great. Uh, so, and usually for this 1 week, they spend like how is planned? Like, is it totally surgeries? They don't go to clinic at all, or like a mix between clinics and surgeries? Or usually, how's the plan for that week spent by the candidates?
So usually the first day is a clinic.
Mm,
We see all the patients, and then we decide what patient is going to have surgery the rest of the week. So it can be around 4 to 8 cases a day. Some
okay.
some places we have 2 or 3 hours running at the same time with
Mm,
different cases.
okay. So just like the first day to see the patients to plan, then the rest of the week they will just be doing surgeries.
Yeah, we do surgeries, and in the evening
Mm,
we check again every case, and we check the what we find intraoperative and the treatment, the philosophy, and the
okay.
planning.
We move back to Dr. Bhatia then. So when you try to enroll or establish this school program into your center, did you face any barriers to help to push this program on?
Uh, no, my hospital has been very kind and accommodative. The issue in the beginning was that to get two ORs, ours is a
Mm,
very busy center, general hospital with a variety of departments struggling to get OR space. So my surgeries being long, they get focused in one OR in general,
mm,
but in order to spread the delegates into two ORs and keep two operations simultaneously, the hospital we once we knew the dates, we for that particular week, two ORs were dedicated for us. And within 15 days of the beginning of the course, I would have operations slotted in for both sides. And then, as Jorge said, I got a couple of my colleagues to pitch in because then we could start surgery in both ORs at the same time.
simultaneously, yeah. Okay.
Yes, so that helped. Luckily, our ORs are reasonably big. Getting three guests in, maybe have one of them or two of them scrub for each operation was possible. In India, we have that facility. So Jorge, me, Alex Muzet, we used to take the responsibility for the guest to scrub for the operation. So, which I feel is a wonderful opportunity for the delegate because they actually can feel what we are feeling.
Yeah, for
Merely
sure.
looking over our shoulders is not adequate exposure for them to understand
The
the
concept.
intensity of a particular exposure.
Mm.
So
Yeah.
in that from that point of view, I appreciate that there was no hitches.
Mm,
The other thing that, as Jorge was saying, was that I, at least in our center, we tried to include similar cases as the ones we had operated to show how they had been operated in the past, the
mm.
intraoperative findings, and the
The
same set
outcome.
of reconstruction. What is the
Mm,
long-term outcome?
mm. Yeah, so
As I
they
said,
can at least because
we want
the
them to have
period is too short
confidence.
for them. Yeah, the period is too short for them to follow up for the outcome.
Yeah.
Yeah,
So
okay.
I think it is important to see pre-op,
Mm.
intra-op, and post-op.
And post-op, yeah, correct. Yeah, I guess this program, and correct me if I'm wrong. This program was not only a teaching program. I think it also opened a chance for research and multi-center studies. So, in terms of patient outcome, how did this, because I saw a couple of articles got published by the fellows, and it actually coming from the four centers together. So this helped to improve the patient outcome by any means?
Uh, I think it does because uh, the most important thing is that we really try to do the best for the patient. That's what all surgeons want. But our philosophy at treatment is like a brachial plexus surgeon should cover all the aspects of treatment. What do I mean? You should cover neurolysis, nerve repair, nerve graft, sensory, motor, vascularized nerve graft, should have tendon transfer, free muscle transfer, arthrodesis, uh, bone osteotomies. So every single aspect of the treatment we cover, and every single surgeon should be very good in all these kind of treatments, not only part of the treatment, so every treatment.
Okay, that's good strategy. So for Dr. Bhatia, like how was the evaluation process for the candidates? Like there was like interview before enrolling into the program. They have like a logbook they need to follow, or like how was the process of evaluating the candidates?
Uh, Actually, I was not involved directly in
Mm,
selecting the candidate, no doubt, but by common consensus, we chose to select people who were already exposed to brachial plexus surgery.
mm,
They had to feel the necessity of improving themselves
mm,
in order to improve their outcomes by visiting the cutting edge centers. And they were in situations where they could arrange to travel these long distances
mm.
over a year in order to get
The
long-term benefits
experience.
for their own patients. So
Mm,
we had to evaluate the candidates based on what sort of workload they were facing in their local centers. What sort of how important brachial plexus was, brachial plexus injuries were. So, for example, highly advanced societies like in Europe or America would have fewer motorcycle accidents,
yeah, for
whereas they
sure.
would be more common in Latin America and
Mm,
Southeast Asia.
mm.
So the people here would were likely to need
The
formal
brachial
training
plexus. Mm,
the day they start practice.
yeah.
So from that point of view, the candidates were selected,
Mm,
and
okay.
then within a day of them arriving at each of our centers, we were able to judge at what level should discuss and take it forward.
Okay. And do they have like an exit exam for the program, or how do you evaluate the graduation from the program?
I
The
think I can answer that because the last stage is always in Guadalajara.
okay, so the evaluation is during the whole year, the whole practice,
Okay.
and the
Okay.
evaluation it's mainly in physical exploration
Mm,
and surgical skills and surgical strategy.
okay.
So, in the last visit, they would explore to this is a patient, so do the history, physical, and then what are your thoughts, your thoughts in the best treatment for this patient, and then it goes to the OR.
Okay. So they only get evaluated during the 1 week they spend, or even if they are away during back at the centers, they get evaluated too.
Okay, the evaluation it's the whole year. Every time that
Mm,
they are at centers, they are being evaluated.
mm,
But let's say the final evaluation, it's during the last week.
Okay, I got it now. Okay.
If I might add,
Sure.
we tried to arrange so that two of us at least would be there at each center.
Okay.
So
Yeah.
that
During the week they are
the
visiting.
effect of their exposure in India, I could review also in Spain. Discuss with them again what was their experience after leaving India and before they came to Spain, or what was the
That's
experience
great
in
strategy actually.
acute and then coming to Spain.
Yeah,
Yeah,
that's great strategy to follow up. Yeah.
yeah. You know, Usama, that to me it's terrible that some surgeons go to a 3-day, 4-day workshop
Yes.
and they treat a brachial plexus injury only with an overline.
Mm.
Forget about the shoulder, don't do brachial
Yeah,
plexus
they
extension,
just focus on one technique only.
and they call themselves brachial plexus surgeons.
Mm.
And I think that that is terrible. I am in Mexico, and you have no idea how many patients I receive from the United States and also from South and Central America that have been operated with only an overline procedure and not a well done because not functioning good.
Mm.
So I think we need to focus on the basics of brachial plexus surgery, like exploration, always explore the brachial plexus, always, not just jump and think
Do that
about
transfer.
reconstruction. Yes.
Mm. Okay. Yeah, I agree for that. Especially, I think for brachial plexus is a quite complex injury, and I guess every patient is unique. So, like, not all the strategies can just copy and paste from one patient to another. Okay. Yeah, I think this is the end of our interview. Thanks so much for your time and coordination, and I appreciate that you try to accommodate me due to the time difference. And I'm very pleased to have you in this interview. So thanks so much, sir.
Okay.
Thank you.
Well, thank you for the interview because we think that, brachial plexus surgeons, it's a big surgeon that has a lot of training. And, in the last NARACAS meeting, I asked the professors, how many brachial plexus surgeons are in the world? And the number is less than 500. If you have 8 billion people with 500 trained surgeons, that is terrible.
Yeah, exactly. The ratio for the patient to surgeon is too little, I think.
Yes, I think that we should have around 5,000 brachial plexus surgeons around the world. There are countries that with over 100 million people has no brachial plexus surgeon.
Yeah, unfortunately.
And it's not only brachial plexus surgery, it's brachial plexus plus peripheral nerve surgery.
Yeah, I guess we need more trained surgeon, and because it's a really quite devastating injury, and helping those patients just to get back to their life or their job is really very pleasant experience for each surgeon.
Yes, and around over 60% of our patients go back to their original work. So
Mm,
surgery is great.
yeah, for sure. I cannot deny. Okay. Thanks so much again, and have a great day.
You too.
Thank
Thank
you.
you,
Thank you.
my
Thank
dear
you.
Neil. Great seeing you
Thank you.
again.
Thank you. Bye. Thank
Bye.
you.
Bye.